And then after that also phone calls are throughout, iska patient hai. Yeah. Most majority of the time goes in that only.
As dean, it would be mainly for, is dean the overall, is it like principal or is it?
Yes. I have to, like tomorrow morning, I have to address first MBBS students to the newly joined, So that also, there is one academic dean position is there, but she looks after mainly like accommodation of students and, the certificates of students and things like that. But rest all, now I'm trying to get one medical superintendent post so that, I can be little eased out. But it is
Okay,
not
there
there
is no
such a post.
MS nahi hai?
No, nahi hai.
So,
I must be doing at least 100 to 150 signs every day, Plus, we have to go to head office, like our head office is in VT and I am at Parel. So it's 20 kilometers every day. Every other day we go 2-3 hours spend there, with the meetings and all those things.
Sir, we are live, so we will now
sure.
keep the conversation on the today's topic.
Right.
May I request digital team to connect Dr. Meenakshi Sundaram and also to Dr. Kotakal.
Dr. Kotakal was there, I think.
So,
no, we didn't see him joining.
I mean, I just
now it is there. Yeah, there he is there.
Good evening, Dr. Kotakal. Morning in the US.
Yeah, it must be pretty early for you, Dr.
Yes.
Kotakal. Sorry to wake you up so early.
No, that's fine. I was having trouble connecting. I was getting some error message 3032, and I don't know what that was.
Okay.
Maybe the meeting had not yet commenced, but
Okay.
I'm here.
Yeah.
This is a new format, certainly.
Right.
Yeah. So should I start sharing my screen?
So we will start it.
Sir, 5 minutes. We will just introduce your.
No, maybe Prakash will check his slides.
Do you want to check your slides?
No, that's fine. I've gone through them last night.
Okay.
Good morning, Gagandeep.
Good morning. How are you?
I am very well, thank you. So, are you guys in Mumbai or you're all virtual?
No, we are all over.
I and Nirmal are on Mumbai. Rest all are everywhere, different places. I think Corona has taught this online thing too well, to us, and it's a big boon now.
Yeah, come to think of it, it has made connectivity so better and
and so much more easily done,
Yeah, but it's I don't think it can replace the in-person.
No, obviously it can't. It can't. That's true.
So AES last year was combined, was a hybrid.
Yes.
But curiously, the AAN meeting this year will be, they're having the in-person one beginning of April, and then the virtual one will be towards the end of April. I'm not sure the reasons why they did it like that. I think they wanted to kind of tailor it to the online format in a different way for some reason.
So,
So shall we start now?
Yes, I think.
Okay, so let me start sharing screen. Or
Good
oh,
evening.
no, is someone else going to?
Let me begin today's program. Good evening, everybody. Good evening, the speakers. My dear friend, Dr. Prakash Kotikal, Sanjay Singh, the CME, the Epilepsy Subsection Convener and Chairperson, Dr. Rathod and Sangeeta. My dear President-elect, Indian Academy of Neurology, Gagandeep Singh, and our EC member, Dr. Sita Jayalakshmi, and Dr. Sanjay Singh is traveling from India to Mumbai to US, so he has sent his recorded lecture, so could be there. I welcome you to the first ever epilepsy subsection activity, and it's a special because we have experts in our Indian Academy of Neurology. In fact, even in my EC, there are two experts, Dr. Gagandeep Singh and Sita Jayalakshmi, both are here. And then we have another two, convener and chairperson, who has worked hard for past couple of months, ever since this subsection has been declared active from November. So they have been working for past 2 months to bring this International Epilepsy Day, EU CME on epilepsy. And I think this is a wonderful beginning, because they all are starting like bang with the 6 to have such a important meeting on an important day. And that too is collaboration with Indian Academy of Neurology with American Indian Neurology Association, and both the president and past president are here. So I welcome you all, and I really congratulate Sita and Rathod to having taken all the pain to bring this. And I'm sure at the end of this session, you all will be excited and learn it. So I hand over my baton to now Sangeeta to take over from here as a CME chairperson. Thank you.
Thank you, Nirmal, and good evening and welcome to all the dear colleagues. Special welcome to Dr. Sanjay Singh and Dr. Kotagal, who have joined from INA, and a warm welcome to Dr. Nirmal Surya, who is the backbone of and who is the one who has helped us a lot in forming this epilepsy subsection. And today is our first program of epilepsy subsection of IN, and I'm so happy that we are having a collaboration with under the IN banner of INA along with our subsection. And we have with us another prominent speaker is Dr. Gagandeep, who is also next president-elect for IN. So I think Chaturbhuj has tried this first program, and I'm sure we, with such good speakers, and we have an eminent moderator for the question answer, Dr. Sita, we will have a very nice program. So I think first I would do is introduction of all the speakers, and then followed by I think we can have so that we don't have to share the screen again. So can I ask Mansi to share her screen? Then this is we have today a world, we also have EU, and tomorrow we're actual International Epilepsy Day. We have also a love forming day, and so I love epilepsy is the really motto, and that's what we should go ahead with. So Dr. Prakash Kotagal, I think for us, all of us, he's synonymous, his name is synonymous with the Seizures Immunology. He's a professor of neurology at Cleveland Clinic, Lerner College, and he has done his basic training at JIPMER, PG and AIMS in India. And then he's moved on to USA. We lost such an important person from India. He's done his pediatrics from St. Louis University and pediatric neurology from Cleveland Clinic Foundation. And then he is a clinical neurophysiology and epilepsy training is also at Cleveland Clinic Foundation. We all know his fantastic papers on figure of 4 posturing, his hyperkinetic seizures having the SPECT findings, dystonic posture of the left temporal lobe, lateralizing sign. I think and whenever my new epilepsy fellows join, I tell them that one seminar has to be on this paper and then you join the reporting of video EEGs. So I think your papers are really landmark papers. So his special interest, apart from seizures, immunology, is pediatric epilepsy and epilepsy surgery and sleep and epilepsy and vagus nerve stimulation. He is currently a president of Association of Indian Neurologists in America, that is AINA. So I welcome Dr. Kotagal. And I'm sorry, I will also finish introducing Dr. Sanjay Singh. May I have the second slide, Mansi? Dr. Sanjay Singh is a chair and professor at Department of Neurology, Creighton University School of Medicine, Omaha, USA. He's the director of CIH Health Epilepsy Center in Creighton University. He did his epilepsy fellowship at Yale University School of Medicine and neurology residency at George Washington University School of Medicine. He's the chief of staff at Creighton University Medical Center at USA. He's ex-chief academic officer of CHI Health. He has got awards like Spirit of Neurology Award by the American Academy of Neurology and A.B. Baker Teaching Award by AN. He has done many community talks, TED Talks, science cafes, and he has visited my center where I had invited him to give Bharucha oration at I think almost 5-6 years back when he had come and he had given a fantastic talk that time also. So welcome, Dr. Sanjay Singh, and I'm very thankful that though you had a very personal problem, but you gave us the recording, and today we'll be playing that for you. Next, can I have Dr. Gagandeep slide? So Gagandeep is a very good and close friend. He's currently a professor and head of Department of Neurology. He's at the Anand Medical College at Ludhiana. He's done a various fellowship in Royal College of Physicians in London since 2019. He's fellow of National Academy of Medical Sciences since 2016. Also a fellow of Indian College of Physicians and Indian Academy of Neurology since 2013. He's honorary associate professor in clinical and experimental epilepsy at UCLA Queen's Square, president-elect of Indian Academy of Neurology. He's secretary general of Indian Epilepsy Association. He's a chairperson of primary care take force in the ILA. He has 98 publications with H index of 21, which is very good. He's got awards like Madurai Neurology Association Award for highest score in MCQ examination at 21st Annual Conference in 1993. So he was a student that time, I'm sure. His also other awards are J.C. Patel and B.C. Mehta Best Original Article Award, as Baldev Singh Oration Award at 55th Annual Conference of National Academy of Medical Sciences, B.C. Bansal and Uma Bansal Oration, is Palatusi Advocacy Leadership Forum graduate in American Academy of Neurology, Dr. G.S. Sainani Oration at Association of Physicians of India at Bangalore, and Smartest Teacher Award at Shine, Chennai 2020. So today we are going to hear a different talk from epilepsy and migraine and not the infection. So let's hear that. And our fourth person is Sita. She's our consultant neurologist at KIMS, Hyderabad, India, and a special interest in epilepsy surgery. She is a coordinator of the Comprehensive Epilepsy Surgery Care Program at KIMS and has done more than 1,000 epilepsy surgeries. He has more than 100 publications in journals. And she's a DNB teacher and has received Master Teacher Award by Shine. She's EC member of IN, GC member of IE, convener of epilepsy surgery subsection of IES. So welcome to Sita. And so now I think I welcome all the delegates who are joining this CME, and I welcome all the neurologists who have joined. We also have on the YouTube. So if you have a problem joining here, you can also see on the YouTube. So can I now request Dr. Kotagal to share his screen and start the talk?
Just a moment. I hope you're able to see my screen.
Yes.
It's a pleasure to join all of you this morning or this evening in India. And it is amazing what technology is allowing us to do. It still doesn't take the place of in-person, face-to-face meetings, but there have been many opportunities that we can now avail of that were not possible even a couple of years ago. So the value of seizure immunology has, in the last 2-3 decades, has come to the forefront as we realized how important it is. Just to start off with this painting by, it's called Raphael's Transfiguration of Christ. It shows 2 events taking place. This was in a paper published by Dieter Jans. In the lower part of the picture, you have this picture of the epileptic boy. You can see he has basically an asymmetric tonic, bilateral asymmetric tonic seizure with eyes looking up into the
Hello.
right elevation.
Sorry to bother. Sorry to interrupt, sir. But your screens are not moving. Your slides are not moving, and you are on the edit mode. It is not on the full screen mode.
I thought I had it on the full screen mode. Let me try again.
Yes, sir.
Now, is it in the full screen?
No, sir. 1 second. I will stop your share from here. I will request you to share it once again, please.
Okay.
Yes. Now you can click the share button and click the full screen option of your PowerPoint.
Okay. Is it full screen now?
No, sir, not yet.
At my end, it looks like it is full screen.
Okay.
So, but no, unless you try to make the window bigger.
So can we just try this once again, else you can continue with this view, if you don't mind. So you can remain in the full screen of the PowerPoint. All you have to do is just go to Zoom and share your screen once more. Let the PowerPoint be as it is.
Except I won't get to PowerPoint if to get to the tabs. Let me try again. Because when I say share and what to share, it says the entire screen, window, or Chrome tab.
You could use
when I go to Windows, then
you could use the option of share entire screen.
okay. And now, can you see the presentation? No.
Not yet, sir. Yes, now I can. Yes, you can minimize this and go to your PowerPoint, sir.
Okay. Actually, I'm in PowerPoint already, so I'll just continue then. So anyway, the way this painting was painted was as though 2 events were taking place at the same time.
So we
the
can't see your slides. You'll have to click the PowerPoint once again, probably. The PowerPoint application.
There seems to be some disconnect.
Yes.
Okay. If it's
The full screen and share.
now, I should go to full screen.
Yes, sir.
Okay.
Yes, perfect.
Now it's good. Thank you. All right, let's continue. So There are a number of features in epileptic seizures, those of focal onset that have lateralizing significance. And some of these are in the form of auras, such as somatosensory aura or elementary visual aura that lateralizes seizures to the opposite hemisphere in either the parietal limbic region or the visual cortex. Then you have other movements such as forced turning of the eyes and head, typically to the contralateral side, away from the side of seizure onset. On the other hand, there's another phenomenon called ipsilateral head turning, where the head may turn to the same side. There are some differences between the two. You can have focal clonic movements. And so they have this long list. I'm not going to read every single line, but you can see that there are a number of phenomena that have lateralizing value. And we'll talk more as we go. And even this is not a complete list because it continues to the next page. And we have a number of other features. I have drawn a line through the second last one, tongue biting, which we now know is not a lateralizing sign. It really has to do with which side of the body, the way the person is lying. So during the course of the seizure, if they're lying to one side, the tongue on that side is likely to get bitten, having to do with gravity more than anything else. So a number of features, as I said, have lateralizing significance. One of the curious ones, which is not during the seizure or interdictally, you can see, is where you have this lady who at rest, her face is symmetric. Even on voluntary contraction, the face is symmetric, but then when she laughs or smiles, you see that the right side of the face is not moving, and she has left temporal lobe epilepsy. The significance of the focal clonic seizure is seen here in this little girl who has Rasmussen syndrome. She has focal clonic seizures involving the left side of the body, and sometimes they would be in the leg, or they could be in the arm, or in the face, pointing to seizure onset involving the right hemisphere. And this is the representation of the homunculus, where we have the primary motor cortex shown in red, and then behind it we have the primary sensory area. We see the somatotopic distribution with the mouth and face are at the lower end of the homunculus, and then you have the hand area, the trunk, thigh, and then the foot is actually represented on the mesial aspect of that hemisphere. Also shown on the mesial aspect is in yellow is the supplementary motor area, and that too has a somatotopic representation. So the head is more anterior, and then you have upper extremities and then the lower extremities. So this often overlaps or is just below the sensory motor, primary sensory motor areas. You also have negative motor areas mesially and on the lateral aspect, where seizure in that area can cause loss of muscle tone, causing the extremity to drop. And so there are some seizures that have that semiology. A series reported from Cleveland Clinic. We had a case report of a young child who had seizures arising from the mesial frontal region, and his seizures were those of stumbling. While walking, he would just stumble, and he would be conscious during them. So this was a negative motor phenomenon manifestation. One of the important caveats is that because you see focal clonic movements, it doesn't mean that that's where the seizure started. It just means that that part of the cortex is being involved in the seizure. You can have seizures that start elsewhere and spread there. So lateralizing value is excellent, but we have to kind of keep in mind the possibility that seizures could start somewhere else and then eventually get to the sensory motor cortex when you see the focal clonic activity. The reliability is very good. In the case of EPC or epilepsy partialis continua, this is a focal motor status involving a very limited part of the sensory motor cortex. And so EPC is one of the phenomena that we can see in patients with chronic Rasmussen's, especially focal dysplasia, infarct, and so on. In this example, you have this young lady. She announces an aura to her parent. So So what you saw here was that the seizure started with this aura, and her aura is that of a tingling sensation of the inside of her mouth and cheek. And then you can see that she presses the seizure alarm, and then she starts with tonic movements involving the face and head and arm on that side. During that, in the early part of the seizure, she was conscious and able to follow commands. So because of how the seizure evolved, we would assume, or we could conclude that the seizure onset is likely near the sensory area for the face and head. And indeed, she did have a focal lesion in that area. In this example, this lady has this prominent turning of the eyes and head to the right with extension of the neck. And that is an important distinguishing factor from ipsilateral head turning, where you don't get that neck extension, you get more of head going down towards the shoulder. So my colleague, Dr. Elaine Wiley, she was one of the first to point out the importance of how version is defined. So if you define it in this way, and these were the terminology that she used: unquestionably forced, involuntary lateral positioning of head and eyes, that it is sustained. It's not just a movement to one side and the head comes back to the middle, but it's sustained. The neck is extended, and then if it goes into generalization, which is typically the case, then we have good confidence in saying that the seizure is coming from the opposite side, away from the side of the head turning, or the forced version. And this has to be distinguished from what we call as non-versive movements, where it's not a sustained movement, and it may not necessarily go into generalized chronic seizure. So this is that original series, and in every instance, the version was contralateral. The other thing that she was a second paper talking about late IPSI version. So what is that? So first you have movement of eyes and head away from the side of the seizure, contralateral, like the example that I just showed. Then the seizure generalizes, and after generalizing, towards the end of the generalized tonic seizure, then the head goes towards the side of the seizure onset. So in this example, what happened here, so you have just the parasagittal channels shown here. So we have the, you can see the left hemisphere, then we have the right hemisphere. So the seizure actually started in the right hemisphere, and then it spread to the left. When the seizure first started on the right hemisphere, the version was to contralateral side, to the left side. But as the seizure evolved, the seizure ended on the right side while still continuing on the left. That caused the head then to turn to the opposite side. So you had late IPSI version to the right, but actually seizure started in the right hemisphere. So this point is clear. So you can have version, contralateral version, secondary generalization, and then followed by late IPSI version. So that's why it's important to look at this from the very beginning. And this accounted for some of the controversy in the earlier literature, where sometimes people would say, well, version is contralateral, others would say, no, it's ipsilateral. And those are based This is prior to the introduction of videotapes, where people give eyewitness accounts. And if you weren't in the room from the very beginning, you came in towards the end of the seizure, you might see this late Ipsy version. Of course, that has been obviated since the advent of video EEG monitoring technology, which came about in the 80s. Ictal vomiting is another lateralizing sign, and typically these patients have seizures arising from the non-dominant hemisphere. Typically from the frontotemporal region. So she has, many patients have epigastric aura. So she arouses, and you'll see that she reaches for the seizure alarm to do that. She touches the nose with the left hand. I'm not sure what that signifies. You can see the prominent automatisms. Then this retching that she has. Some manual automatisms. And ictal vomiting. So this is, and you can see the automatisms to the right hand as well, briefly. So not all patients have, this pronounced degree of vomiting, and she would do it with every single seizure. But there is an association between the epigastric aura and ictal vomiting, and invariably the seizures are lateralized to the non-dominant hemisphere or the right hemisphere. The other features of the seizure, as you can see, are very characteristic of seizures arising from the mesotemporal lobe. Other manifestations have to do with language alterations during the course of seizures. So speech sounds, we have to distinguish what kind they are. So if there is actually words that you can make out, that is of lateralizing value. But just, if you have just a vocalization, that is not lateralizing. If there's ictal speech, words you can make out, that is typically from the non-dominant hemisphere. Why? Because the language dominant hemisphere is not involved in the seizure, and they can continue speaking. Speech arrest is not lateralizing, whereas dysphagia, either ictally or post-ictally, is of lateralizing value. I'm not sure what happened. Just bear with me here. Sorry about that. Some of the colors disappeared. Are you able to see my slides?
We can see it, sir.
Yes, sir.
We can see it, sir.
But it's not moving for some reason.
No, it is. I think something different has opened. It is without color.
That's what I mean.
Yeah, the colors have gone, I think. Yeah, it's
Okay,
come back. It's
hold on.
come back.
Okay. Is it in full screen now?
No, sir, not yet.
I wonder why that happened. Apologize for that. I'll try. So we saw this one. Okay, let me go to the next slide. Okay, so the significance of the post-ictal dysphagia was shown by Michael Privitera. So they actually have patients read a paragraph, and they tell them ahead of time, we're going to ask you to read this paragraph after the seizure, and noted how long it took before they were able to do that without making errors. And you can see that patients who had left temporal epilepsy, it took them longer than a minute before they were able to read correctly. Many of them even longer than that. Whereas with right temporal epilepsy, in about 20 seconds or so, they were able to speak. And so they, if you took the 60-second cutoff, they found this to be a very useful lateralizing sign. Postnectal dysphagia. So that's important, the importance of the postnectal interview. Both during and after the seizure, it's important that the nursing or the technology staff are doing that for us. This is a gentleman who has ictal speech. So you can see here that just spontaneously, he just starts talking. You can make out what he's saying, but it seems very inappropriate to the situation. There seems to be some awareness during the seizure as well. Typically, they have amnesia for this. So you could say, well, why is this not a simple partial seizure? The fact is that they're also amnestic, so there is altered awareness typically as well. And so this is lateralizing to the non-dominant side, typically the right hemisphere. So in this seizure, there are a number of different features that worth noting. The aura is an abdominal aura of nausea. You can see she clutches her abdomen. Note the right hand. So there are a number of features. The epigastric aura, the oral and manual automatisms, the dystonic posture of the right hand, during which she is manipulating the right hand with the left. So the posturing is on the right, the automatisms of the left side. This is then followed by version with this extreme extension of the neck and head and eyes deviated to the right side. Then followed by the figure 4 posturing with the right arm extension, left is still flexed, resembling the figure 4, followed by bilateral tonic-clonic movements. So a number of phenomena here are lateralizing. So it's not only lateralizing, but also localizing value given the type of aura, the automatisms that we see, and also the sequence in which these symptoms are taking place. And in this paper, this was I did this during my fellowship year. that the dystonic posturing was always contralateral in every instance. This was a pure set of patients with mesial temporal epilepsy who was seizure-free after epilepsy. It was contralateral, and so was version was contralateral, and they agreed with each other in every instance. If they had automatisms of one hand just by itself, that was not lateralizing. It could be ipsy or contralateral. But if you had dystonic posturing, the posturing was contralateral and the automatisms were ipsilateral. So if there's automatisms by itself, it's not significant, but your automatisms associated with tonic or dystonic posturing of the opposite side, then it becomes useful. And sometimes that's what draws our attention to that. In fact, that's how I was, in the first index case of the dystonic posturing was because I was taken up by this very rapid hand automatisms this gentleman was showing. Then after watching it a few times, I realized that actually the opposite extremity was doing something strange, was having this dystonic posture. The sequence in which these occur, this is like a idealized, scheme of progression. So you have bilateral automatisms, then one side may become dystonic or tonic, while ipsilateral automatisms continue. The seizure may end there, or it may continue on into version and secondary generalization. You don't always get version, so in which case you may have some useful information from looking at the figure 4 posturing with the arm that's extended, that's contralateral. In those days, in the 80s and early part of 90s, nearly all patients who had mesial temporal epilepsy, as well as any kind of focal epilepsy, we evaluated them with subdural grid recording until the 90s, when the MRI got better, was able to show cirrhosis. PET became available, and we could see hypermetabolism, and then we did not need to do the invasive recordings like we did. But nevertheless, this showed us in nice detail how seizures evolved. This gentleman had dystonic posturing of the right hand, and seizures started. This is the basal temporal lobe shown in the bottom left here. And so the mesial contacts, showed the earliest changes. This is kind of over the parahippocampal gyrus. And then when the dystonic posturing occurred, the ictal discharge was still confined to the mesial basal temporal lobe. And we did not have involvement of the suprasylvian regions where the motor areas are. That's why we postulated that likely the seizures arise from the basal ganglia structures, because we have connectivity both from the hippocampus and from the amygdala going to the region of the nucleus accumbens septi, or the ventral globus pallidus, with the stria terminalis and the fornix. And subsequently, that has been shown by ictal spec. This is the work of Sam Berkovic and Mark Newton, showing this hyperperfusion in patients with dystonic posturing, hyperperfusion involving the basal ganglia structures. It's not just hyperperfusion that we see, but we can even see interictally that there's hypermetabolism. So this patient who has profound hypermetabolism in the right temporal lobe with left side dystonic posturing, you see hypermetabolism also involving the basal ganglia. So it's been postulated that the pattern of hypermetabolism is not just, maximal in one area, and then radiating out, but it's actually showing the structures, brain structures, that are being involved as the seizure propagates. Another lateralizing phenomenon is that of unilateral eye blinking. In this instance, this boy has a left temporal lobe tumor. You can see the blinking of the left eye. Then it becomes more tonically contracted, and then the right hand becomes stiff. So that's how a dystonic a tonic posturing is. Either it's inflection or extension. but it does not show that rotation element of dystonic posturing, the chorioathetoid movements, and so on. Andrew Bleasel, who is in Sydney, when he was in Cleveland with us, and Pong Kankir with Hana, we did this project looking at seizures for different lateralizing signs and looking at the inter-observer agreement as measured by the kappa index. So the kappa index is less than 0.4, it's not significant. More than 0.7 is excellent agreement between different observers. Because I might say a particular sign is present. Dr. Gagandeep may say, no, I don't see it. And if Dr. Surya agrees that it is present, then 2 out of 3 people have said it's there. So we said, okay, we're going to call that it is present. So that allowed us to measure inter-observer agreement, as well as how common a sign is and the positive predictive value. So you can see dystonic posturing had good agreement between observers. It was a fairly common sign in this particular subset of patients we were looking at. And compared with that, the kappa agreement for tonic posturing was not as good as dystonic posturing, and was not as good for the what we call lateralized ictal paresis, immobile limb, where one side is not moving. That's contralateral, but in terms of how often it is seen or how often people agree that a sign is present. We have similar agreement for extratemporal seizures as well, shown in the third column. So with the unilateral blinking, so this is, it has a lateralizing value. The mechanism is not fully known. Likely it has to do with involvement of ipsilateral corticospinal fibers. So there's been some more recent papers that have come out about ipsilateral blinking and postulate about that is that it seems to originate, we see it in seizures coming from the anterior temporal lobe. Another phenomenon which is useful when it is seen is automatisms with preserved responsiveness. Invariably, patients who have automatisms have altered awareness, but there are some patients who are they're responsive during the course of these seizures, and typically they have seizures from the non-dominant side. The other lateralizing feature is that of postnectal nose wiping, where patient wipes the nose with one hand, and typically the hand that is used is ipsilateral to the side of onset. It is of value for the temporal lobe cases, but not for extratemporal. Again, the mechanism is not known. Is it due to paresis or neglect, or are there some nasal secretions? We don't know. We had a recent patient in our epilepsy monitoring where this nose wiping was prominent, and my colleague Dilip Nair was interviewing the patient at that time. And he was actually responding at right temporal lobe epilepsy, and said, are you feeling something in your nose? Are you itching? Are you having any runny nose or anything? And the patient said, no, I don't have anything like that. I just don't know why I'm doing it. So the patient realized it was an involuntary movement, but had no control over that. So just showing you that in temporal lobe epilepsy, it has has good value, but not for extratemporal. Going on to the figure 4 sign, what happens here is that as the focal seizure evolves into the generalized tonic-clonic or bilateral tonic-clonic seizure, the tonic features and clonic features also, they don't necessarily occur symmetrically. They often are asymmetric. And because of that, you have one arm that becomes stiff first, and while the other is still flexed. And this then leads into the bilateral tonic-clonic. So this is just a photograph showing the similarity to the number 4. So the arm that's extended is contralateral. So this version to the left, you can see very rapidly extension of the left arm, left leg, and figure 4. But it can be very fleeting. So that's one challenge, is that it happens so quickly. So looking at the seizure carefully from the beginning is important. Now, interestingly, this is seen also in patients who don't have focal epilepsy. So just a note of caution. So that just because you see that figure 4 sign, it doesn't mean the patient has focal seizures necessarily. We see, let's say, patients who have generalized epilepsy, as in JME, and there are some asymmetry. Some patients have asymmetry, and you might see a figure 4 posture. We found it to be present both in temporal lobe and extratemporal cases with a high frequency and good predictive value. Not as good as version, but pretty good, about 90%. And this is the comparison with version. And in the earlier paper, we only saw it in patients with partial seizures, but I have to walk this back because I just told you that you can see it in patients with generalized epilepsy as well. Figure 4 and version typically agree with each other. There was one exception. It was contralateral in 17 out of 18 patients. There was one patient where, and I've seen this only maybe 2 times ever, the evolution right side version, right side figure 4, then you have bilateral tonic-clonic movements, and then finally towards the end of the seizure, you have this figure 4 changing sides, similar to the ipsilateral head turning. So it's the same explanation for this. Sorry, this is repetitive. One of the interesting things as to why patients who have right temporal epilepsy, they are more aware during the seizure, may have to do with the connectivity as shown by ictal SPECT. And so this work of Ed Hogan, and so that you can see, this is the temporal lobe hyperperfusion here on the left side. You can see this hyperperfusion in the upper brainstem. Contrasting that with patients with right temporal epilepsy, where we don't see that pattern of hyperperfusion. So the connectivity appears to be different in right temporal versus left temporal. That explains some of these different features. This is this lady with automatism while retaining awareness. So she is carrying on this conversation, even following instructions, reaching for a pen and describing what it is. But subsequently, she has amnesia for this, right temporal epilepsy, right mesial temporal epilepsy. There are a number of lateralizing signs, and others have also, looked at, studied these signs, and in terms of how common they are and what is the predictive value. This is work from David Marks from UCSF. And these are kind of features that we kind of think about when we are discussing patients for epilepsy surgery. Sometimes you have some features that are concordant and others that are discordant. So we have to kind of take that into account. Now, we know the localizing value of auras, not just somatosensory and visual, but you can have epigastric auras, psychic auras that are olfactory, that are typical of temporal epilepsy. You have different auras in frontal, temporal parietal regions, posterior cortex. We have formed visual hallucinations and auditory auras. Perisylvian onset seizures have some of the taste and autonomic manifestations that are seen. Some patients actually have multiple auras in the course of the same seizure, especially with right side onset. Because they're conscious, as the seizure is evolving, so this patient had seizure starting from the mesial temporal lobe with aura of nausea and fear, and then later, as it spreads more posteriorly, then she describes this. She would see this clock in her visual field, the clock face, and so this reflects the fact that they are aware during the seizure. Other manifestations like automatisms now have been shown. This work by Jerome Api from when he was in Cleveland with us, that the automatisms are occurring when the seizure discharge spreads to the insular opercular region. We know the localizing value of seizures such as this one, abrupt onset, bilateral, tonic, asymmetric features. Chronic jerks at the end, and this person's seizures arise from the supplementary motor area, which we were able to successfully resect, and he's been seizure-free and off medications. So this is very characteristic of SMA seizures. You have other individuals who have very characteristic involuntary laughter like this. He feels something, he has like an abdominal sensation, but then he has this very pronounced laughter. He is 18 in this, at the time this was recorded, but the seizures began when he was 4 years old, and he had a hypothalamic hamartoma. So again, so localizing value of seizure like this, you all are quite aware of. We have tried to look at cluster analysis, looking at statistical measures to see what symptoms correlate with each other. And so we have unique features like hyperkinetic movements, posturing that are seen with frontal lobe seizures that tightly correlate with each other. We can also look at the progression of symptoms and how these take place in frontal lobe seizures, in temporal lobe seizures, and distinguish them. In terms of how the semiology compares with other modalities, so this is work by Susan Spencer, mesial temporal lobe cases, the scalp EEG versus other tests, the neuropsychology and WADA and so on. Some more recent work looking at MRI versus SPECT and PET. This is the likelihood of being correctly localized. Sharif Alwan, who was a previous fellow, did this work with us, and we looked at seizures independently, 3 observers. Sharif collected the data from us and only told us what aura the patient had, and then we had to decide what type of seizure it is, where it's coming from, which side, and then which lobe. And you can see the semiology compared well with other modalities, like this is scalp EEG, intractable and ictal, as well as MRI, and it compared favorably. Also for localizing value, that comparison was very good. Of course, somebody is non-lesional, then semiology is clearly better. And we also found this similar to PET as well. The blue bar is PET. Not every patient had PET scan, but about 2/3 of the patient had PET scans as well. Just to kind of wrap up here, because I may be running out of time, we have, this is from Hans Luther's, his work, so that you may have a patient who has focal clonic movements taking place, but the seizure may have started somewhere else and spread to this region. So he has given us the concept about the epileptogenic zone that has, that is around this epileptogenic lesion, the area of spiking or the irritative zone. So these are the important concepts we have to keep in mind when we're studying seizures with different modalities, including video EEG, MRI, PET, and others. More recent iteration of this by Lara Jiha, talking about the different epileptogenic zones. Now, the thing is that it's something that we define this in retrospect. Once you've done the resection and the patient is seizure-free, then you know that, yes, this is the area that you remove to produce seizure freedom. There's been work done by people in France and Italy looking at the epileptogenicity index. This is based on stereo EEG recordings. And a lot of work done by Petri and the Bancode School. And here they're trying to correlate semiology with the involvement of the EEG activity and correlating that. So I'm not going to get into detail with this, but they're trying to correlate that. Some of the more recent work that we published recently in case of hyperkinetic seizures is that there are different types of hyperkinetic seizures with different ictal spec patterns that are seen. So type 1 is one where they kind of sit up and lay back down up, kind of in a vertical plane. Type 2 hyperkinetic is where they're spinning around in bed, turning over and over. Type 3 is a combination of the two. So these are telling us, giving us information about not only where the seizures start, but how they propagate. So to sum up, it compares well with other modalities. It's excellent for seizure lateralization. Semiology is useful for localization. The pattern of origin and spread, as the seizure evolves, we have to pay attention to that. When you have different seizure types with different ictal EEG patterns, be aware that it's possible this patient may have more than one epileptic focus. When there's discordance, you need to resolve that before you decide what you're going to do with placing invasive electrodes or doing the resection. And no doubt the semiology has taught us a lot about how the brain is, different areas of the brain are connected with each other. Keep in mind, MRI only gives us the anatomical substrate, but also with EEG and with functional imaging, it's helping us understand epileptic networks. So I'm going to stop sharing my screen. And turn back to you.
Yeah. Thank you very much, Dr. Kottakkal. It was an excellent videos. It was really nice revision of lots of semiologies. Would you be waiting till the end, or should we ask you the questions now?
If I could take care of the questions now, I think that would be ideal.
Yeah. Yes, Sita?
Yeah. Thank you, Dr. Prakash. It was a very, illuminating talk, and I always enjoy your talk of seizure semiology. This is, I think I'm listening to you for the third time, and always
something new.
We get new points from your talk. So actually, always I have a doubt whenever we review the seizure semiology. At what time point from the onset this semiology has a localizing value, and means how do you decide the significance of a particular sign in the semiology?
And if I may add,
that's a good question. Yes. I think that obviously when the seizure goes into the bilateral tonic-clonic or generalized tonic-clonic, the seizures everywhere. It's propagated, far and wide. The challenge is that different patients their seizures will evolve based on how rapidly it's spreading, and this may have to do with anti-seizure medication levels, may have to do with other factors like sleep deprivation. So these are the things that make it more likely for the seizure to spread widely and become generalized. So I think I would rather look at it from the relative standpoint. So in the course of the work that we did for cluster analysis, so we took a seizure and we looked at the duration, and then we kind of broke it down by thirds. You could do it by tenths, I suppose. But the main part is that these symptoms that occur at onset are likely generated by areas close to the ictal onset zone. Whereas symptoms that occur later may be are obviously more likely to be due to spread. But I don't think we have a hard and fast time frame. I would look at it more in the relative scheme as well.
Okay, now this applies to the so-called automatisms which have lesser specificity. So in few papers they say it is significant if it occurs within first 10 to 20 seconds.
That is, I think that in general
Even
that holds true. Correct. That holds true in general. But I think one of the, like I showed you that by Jerome Oppie from the SEG, that the SEG identified the ictal onset in the mesial temporal lobe, but then very quickly it spread to the insular opercular region, and then you're getting the oral automatism. So then itself, the seizure has spread outside the temporal lobe. So I think it's equally important to look at the sequence of how the symptoms evolve. I think that is important. Another challenge we have is we have patients with epigastric aura. In fact, the one that I showed you with all the dystonic posturing and everything, we got rid of her automotor seizures, with automatisms, but she continued to complain of epigastric auras even after going back for, she actually had, I think, 3 surgeries on the temporal lobe. There was nothing more to remove the temporal lobe. So her seizures were now involving a different part of the brain. So I think that many of these symptoms are due to spread, but it's the way in which they start and how they evolve. I think that is the important thing. As we learn more and more from intracranial recordings, I think that becomes more clear to us now.
Okay, thank you. Yeah, I have always another question, if the time permits. Does the semiology, is it influenced by the substrate? For example, if you have hippocampal sclerosis versus a focal cortical dysplasia in the temporal lobe. So we see patients with the cortical dysplasias with a racket seconds. They don't present like a slow evolution which we see in a temporal lobe epilepsy. So do you think does the substrate influence the semiology?
Well, actually, I think you may know more about this than I do. This is my feeling is that I think in mesial temporal lobe epilepsy, especially the kind that doesn't generalize, so especially the patients who don't go into bilateral tonic-clonic or GTC, in MTS, I think we see a more gradual evolution of symptoms, whereas patients who have malformations or neoplasms, I think there's a more rapid spread taking place. That's my personal bias, but I don't have data to back that up.
Agreed. Yeah, thank you.
Yeah, I think we should go to the next talk. If there are no more questions. Gagan, you wanted to ask something?
No, I just wanted to echo Dr. Sita's statement that this is the third time that I'm listening to this talk, and every time something new comes up.
Yeah, that's what I agree entirely. So when I asked him for the topic, I said, this is the topic which we all love from you. Okay, thank you, Dr. Kottagal.
May I remind you,
we are always learning new things.
Over time,
new papers are coming
Sangeeta,
out.
You will need to move.
Yes. Can we move over to Dr. Sanjay Singh's talk? Mansi, can you start the video? Thank you, Dr. Kottagal.
So thank you for inviting me to give this talk. I want to thank Dr. Sangeeta Rawat for this opportunity, and also Dr. Nirmal Surya and Dr. Gagandeep Singh. I've been asked to talk about epilepsy management, the future. So what I plan to do is tell you a little bit about where we are today, and then I will take you on a whirlwind tour or what the future is going to look like. So as you all know, we currently have this 4-phased evaluation for the intractable epilepsy patients, more of an epilepsy surgery sort of evaluation. Now, every epilepsy patient, as we know, requires an MRI and an EEG, but this is what the others that are more intractable, the 30 to 35% of patients, that's what they require. So, you know, the ictal SPECT scan up here, you know, your MEG scan and the magnetic source imaging over here, and then the stereo EEGs that are down here. So that's where we are. One important part of management of epilepsy is clearly medications. And so this is over the years how medications have developed, and we have seen in the modern era of epilepsy, which I would say from 1990 onwards, we have seen a number of new medications that have come out. And so that is very exciting, a number of new anti-epileptic drugs that gives us a lot of options for treatment. We also have resective epilepsy surgery for temporal lobe and also for extratemporal lobe epilepsy. And then brain stimulation or neural stimulation technologies like the vagal nerve stimulator, the deep brain stimulator, the responsive neural stimulators. This is where we are, particularly in terms of drugs and these therapies. But if you look at the Kwan and Brody's data, right? If you look at their data from before the original Kwan and Brody study, and then if you look at their data from 2018, right? There really has not been a lot of difference. So the number of people who continue to be intractable has not changed that much with all these new medications that we have. And the number of epilepsy surgeries, and then obviously the neural stimulation techniques, the total number of patients that actually undergo these procedures is very, very low, and from a global perspective. Even in the United States, that number is not very high. We have those numbers from the National Association of Epilepsy Centers. It's not very high. And apart from temporal lobe epilepsy and certain extratemporal lobe, particularly lesional epilepsies, the results are not uniformly positive. So clearly, we haven't moved the mark much, unfortunately, despite a lot of these discoveries. And some of this is because we have the same animal models upon which we test all of these anti-epileptic drugs, new candidates. And then if they work on those animal models, then they progress. So if the paradigm has remained the same over the last several decades, and therefore, I think we have not been able to move the mark much. So I'm going to talk about, I have an ambitious agenda. I want to really touch upon a lot of this new and exciting advances in the field of epilepsy. So we'll start out with personalized medicine. What does that mean? The genetic technologies. And then talk about cerebral organoids or brain in a dish, artificial intelligence, epigenetics, the Tdcs in epilepsy, gut microbiome, incisionless brain surgeries, and then neuroprotection, and see where we go. So personalized treatments of in epilepsy, what do we mean by that? So essentially here, what we are talking about is that instead of throwing a medication at an entire patient population, we want to tailor treatments to individuals. So personally tailored treatments, that's what we want. And that's personalized medicine. So epilepsy has a number of genetic abnormalities that we know, and can this help us in directing therapy? So the real revolution has been in genetics, and as you know, a recent Nobel Prize was given for CRISPR technology. This is a gene editing technology. So this can literally go and edit your genome in a way we have never been able to do in human history, right? And so this can really help us in a major manner. So there is at least one company in the United States that has started this process. So what do? You take blood from a patient. They do their whole genome sequencing for that patient, right? They find the abnormality, genetic abnormality that may be contributing to epilepsy. They put that same gene abnormality into a mouse by CRISPR technologies, right? And now this mouse has exactly the same problem that the patient does. And then they test a bunch of drugs, not just anti-epileptics, but a bunch of medications, so even up to 800 medications, and then produce a report for the epileptologist. And they tell them these 5 medications are likely to work in your patient because we have tried them in the mouse model with that same genetic mutation. It seems to work in them. So this is what personalized care based on all the genetic technologies would mean. So I wouldn't say it's in mainstream clinical medicine yet in the United States, but it is, it is there. Now, what about the brain in a dish? So now we are growing organs in a Petri dish, and the brain is not any different. Organoids, as you know, are 3-dimensional biological structures grown in vitro from different kinds of stem cells. So the idea is to grow the brain in a Petri dish. Now, these are all somewhat recent phenomena, but this is how they've grown. So what you do is you take skin cells, right? And then you reprogram. There was a Nobel Prize given for this. You reprogram the skin cells and produce human pluripotent stem cell. So induced human pluripotent stem cell. Now, these stem cells can then form neural cells, right? Neuroectoderm, right? And then you put them in a special sort of environment, and you can grow that cerebral organoid, right? So essentially, you get skin cells, you change them into pluripotent stem cell, induced pluripotent stem cells. They can then give rise to neuroectodermal progenitors, and that can then give rise to the brain. Right. So once you start growing a cerebral organoid in a Petri dish, how is that helpful in the world of epilepsy? Well, what you can do is you can understand neural circuitry, right? We can do our patch clamp and other technologies on this cerebral organoid, and you can test various medications on this to see how they would work, or not just medications, but therapeutic modalities. And you can do drug screening and other, sort of biomarker studies on this. So human brain organoid models of developmental epilepsy. So this is some work that has been very recently done, and it's based on some of the older work earlier this decade. And so models with periventricular heterotopias, progressive myoclonus epilepsies, those kinds of things are being looked at with this cerebral organoid model. So there is a real potential here when we are doing this. Now, it also brings with it some interesting sort of ethical dilemmas, because cerebral organoids, the mini brain models that were developed by Harting's group in Johns Hopkins and the UC San Diego group, they can generate these cerebral organoids that have been grown in Petri dishes. They can generate spontaneous electrical activity, right? Now, as epileptologists, we would think that's exciting, because then we can use this for study of epilepsy. Because the problem we've had is we have studied epilepsy in animal models. And really, brain and brain disorders are what are different between humans and animals. So here, instead of animal models, you have cerebral organoids, human brain organoids that you could study it in. But the ethical dilemma is, are these cerebral organoids that we are growing in a Petri dish, if they can generate spontaneous electrical brain activity, are they actually conscious? Are they alive, quote unquote, right? Now, cerebral organoids now can be kept for 1 to 2 years in this. And at 9 months, what they're seeing is a significant change. Remember, 9 months is when a baby is born. They see a significant change in the cerebral organoids, right? So it certainly has great potential for us in epilepsy, sort of in the field of epilepsy, but it also throws up some ethical dilemmas, I think, that we will need to be aware of. Now, what about artificial intelligence? How much do we know, and what is this responsible for? So AI, as you know, artificial intelligence, sort of they're able to perform tasks that may normally requires human intelligence. So the algorithms are pretty powerful. So the first FDA-approved AI system, artificial intelligence system here in the United States has been approved for stroke care. So essentially what happens is that it monitors all the CT scans. So like in our health system, including our university hospital, there's an algorithm that is monitoring all CT scanners. It picks up any large vessel occlusions, and then it will page the neurologist on call, right? And the interventional neurologist on call that there's a large vessel stroke, right? Why is this significant? Because earlier it used to be manual image processing, preliminary read, emergency room, then referrals, then this used to take 2 to 3 hours, right? Now it does this in under 6 minutes. So 6 minutes it can do this. And as you know, every minute is brain cells. So this is really a major advance. And right now, these kinds of technologies are monitoring all the emergency room, all the CT scanners in our health system. And anywhere where they detect this, they tell us. They not only inform us that there is maybe a large vessel occlusion, they also send us all the pictures, the CT angiograms, the CT perfusion scans, all of those pictures are sent all within 6 minutes. So it is revolutionizing stroke care in this country in a major way. So our group has been doing this work on artificial intelligence in EEG and epilepsy in collaboration with our colleagues from the School of Engineering at Lincoln Computer Science Department. And so we've been able to develop a system that can pick up seizures. So if you look on EEG, it can pick up a seizure, right? Obviously, it has certain sensitivity and specificity to it, but it does. And now we are moving on to a technology that was found as a byproduct here, where we might be able to predict where the seizure onset zone is, and not by recording EEGs and those kinds of recordings. This is by network coherence between the brain. So it's a lot of math. I'm not going to bore you with the math, but this AI system is going to play a major role in all of medicine, including epilepsy, in times to come. And it might help us because it'll give us a new perspective of determining seizure onset zones and also detecting seizures. And can you imagine across large countries like India, where you might not have neurologists or people experienced in EEG reading, if you have an artificial intelligence system, an algorithm that can read it and alert the physicians, that might improve care substantially. The next concept I wanted to touch on is epigenetics. So the way I generally explain it to an Indian audience is that genetics is like your computer hardware. They're like your DNA, right? But epigenetics is like your computer software. You may inherit a good or a bad gene, but epigenetics has the power to switch it on or switch it off, right? So that's the power of epigenetics. It can switch on or switch off genes. There are drugs that are based on this epigenetics. They're called epidrugs. And how does it switch on and switch off genes? Either by methylation of the DNA right here, right? Or by histone modification. So histones are the things around which your DNA is wound around, right? So histone modifications or sort of microRNAs or non-reproducing RNAs. So that's the kind of techniques that are used in epigenetics. So, your genome obviously has a major role in epilepsy. Epigenetics has the power to alter it and is also affected by metabolism. So it'll have some role in this. So not just epilepsy, a lot of neurological disorders have, epigenetic changes and patterns to them. Epilepsy certainly has them in histone alterations here. These are the three technologies that have been studied in epilepsy. So DNA methylation, histone modification, and non-coding RNAs. They have studied this in animal models of epilepsy and also in resected human tissue, right? So a lot of good work has gone into this. And I think we're at the edge of where we can have targeted approaches to epigenetic sort of therapeutic agents now, where you can have DNA methylation, histone tails, microRNA regulation. So all of this, can alter cellular gene expression profile and then promote inhibition of epileptogenesis and its progression. So clearly, this is things that we are really, this kind of methodology of treatment will bring us to a whole new era in epilepsy therapy, right? It can also find biomarkers like it has done in other fields, including in dementia. And then epi-drugs for human drug therapy. And then this is the current ones that are being used in therapy based on epigenetics. They're mostly for oncology purposes, but it has tremendous potential even in neurological disorders, including epilepsy. Now, what about this TDCS? What is that? That's transcranial direct current stimulation. So instead of magnetic stimulation, you're doing direct electrical stimulation. We have just acquired this technology at our center and just starting trials for epilepsy at our center. What it does is that you have an anode and you have a cathode, right? And so what is the idea in epilepsy? An epileptic focus is where there is hyperactivity, right? And so what do you want to do? You want to inhibit that hyperactivity. And so how do you do that? You place a cathode at the seizure focus, and that will then diminish excessive electrical activity there, and therefore will decrease the chances of seizures. So this is the concept that is there. Cathode decreases electrical activity and therefore decreases seizures. So this is a non-invasive, completely non-invasive brain stimulation technique. It's done through the electrodes that are there, right? Now the devices are pretty sophisticated where you can actually put the MRI of the patient and you can be pretty accurate where a mathematical algorithm will tell you how to stimulate so that the maximum electrical stimulation is at a particular point, right? 27 studies so far, sort of 9 were sham control, 18 were uncontrolled trials, so early days, but still it's there. 84% of the included studies reported a reduction in seizure frequency. That's a pretty robust number. 21 out of 25 studies showed that. And 43%, 6 out of 14, showed a decline in EEG epileptiform discharge rate. So it gives you the basis that you want in these kinds of fields. The cathodal TDCS is both a safe and is proving to be an effective technique for seizure control in these patients, drug-resistant patients. So a new neuromodulation technology that we must become familiar with. Gut microbiome. So what is this? So this is the bacteria and other microbes that live within our body. We have learned that about over 100 trillion of them live in our body. The number of microbes outnumber our cells, human cells, 10 to 1, right? The majority live in our gut, the large intestine, and the number of genes in all the microbes in one person's microbiome is 200 times the number of genes in the human genome. So when they live within our body, how can we think that they will not affect everything that we do? So NIH has this human microbiome project, which tells you about all these factors. We have learned that it does affect neurological disorders, cerebrovascular, neuropsychiatric, neurodegenerative disorders are affected by it. But what about epilepsy, right? The communication between the gut microbiome and the brain is called the microbiome gut-brain axis, right? So that's the gut-brain axis. And recent studies have shown that gut dysfunction or dysbiosis, which is affecting the microbes, is involved in the pathogenesis and susceptibility to epilepsy, right? So let's take your ketogenic diet or modified Atkins diet, the two diets. They obviously have an impact on the microbiome that is there inside our body, and therefore cause alteration in this gut-brain axis, and therefore must play a role in epilepsy control, right? And you can reconstruct intestinal microbiome through other technologies too. So essentially what happens is that sometimes in early life, because of antibiotics, infections, delivery method, diet, you cause dysbiosis of the microbiome in there. The microbiome causes gut-brain axis to be altered, right? And then there is a potential to correct it either with diet or prebiotics or probiotics or antibiotics, right? So this is a new way of thinking about this. But let's see. How does the gut affect the brain? How would that happen, right? So there is the hypothalamic pituitary adrenal axis. There is also the synthesis of chemicals or compounds that can go cross the blood-brain barrier and affect the brain, right? Also vagus nerve signaling and the endocannabinoid signaling. So lots of methodologies by which this gut-brain axis works. Some work has been done in alteration of gut microbiome in drug-resistant epilepsies. All of them within the last 3 years, 3 to 4 years. And it's giving us some good initial data. These are, mostly retrospective studies, but giving us some good initial data that if we alter the human microbiome, right, then we can alter the gut-brain axis, and then we can have a positive impact on seizure control. So we are just starting down this road, but initial work has been done. I also wanted to touch on this science because it is a revolutionary science in medicine today. It's called senolytics, and so it is going to have an impact on everything that is related to aging. And as you know, in epilepsy, the majority of new cases of epilepsy are found in people over the age of 60. So aging is a very important risk factor for epilepsy. So what is senolytics? So senolytics, what it does is it decreases or eliminates aging cells. So what happens is that you have a cell that ages, right? And then it affects the surrounding cells and gets them to start aging too. So senolytics is you kill all the cells that are in that aging process, right? And so you prevent the surrounding cells from getting affected and getting and to age. So this is a new weapon in the war on aging, really, senolytics. And so it is really in its infancy. It's only come into its own in the last, I would say, 5 to 10 years, but it's going to have a major impact on this. So I did want to share this with my colleagues because this will have an impact on all neurological disorders of aging. Now, what about imaging? So imaging is sort of fascinating. We have these large Tesla magnet MRIs, 1.5 Tesla is the common one, but then 3 Tesla, there's also 7 Tesla and other magnets, which are humongous magnets put in the basements, and they're very expensive, and the test also is expensive, at least in the United States, it's very expensive. So there is this concept of micro Tesla MRI, new technology by which the MRI would be the size of a football helmet, right? And so the initial images were not very clear. They were sort of grainy, but the images have improved now. I won't go into the technology that is used here because it is sort of unique in its nature. But you can see that the images are now improving quite a bit. Particularly, images have improved for strokes, for bleeding, those kinds of things. So, and these are leading to these portable MRIs. So this is a portable MRI just approved in the United States, where you can put it on wheels, take it to a neuro ICU bed, and just put the patient's head in here, and you can get an MRI. So you can see a neuro ICU with this approved technology now. This is about $50,000 here in the United States. It is much more affordable than the $3 million 3 Tesla magnet MRI that you see. So this is important and new technology that we must be aware of. Now, whenever we think about the non-medical options for epilepsy treatment, surgery is an option, resective surgery, but it obviously has its own morbidity. So this is technology where you use focused ultrasound. You do it in an MRI machine, focused ultrasound to burn pieces of the brain out. It is currently approved for attention tremors, in which you burn a piece of the thalamus out, and also for Parkinsonian tremors, right? But initial studies have started for epilepsy. So what happens here, we have this technology at our center. We are the busiest site in the United States for this procedures. People come in from all over the country to get these procedures with us. It's an outpatient procedure. They come in walking, they get this in 2 to 3 hours, they go home, right? So it's an outpatient procedure. And this is really revolutionizing neural intervention, neurotherapeutics, where you have incision-less brain surgery, right? And there have been 4, small trials that are underway in epilepsy. The idea is also to either to burn the anterior thalamic nucleus, like we do with the deep brain stimulator, where we target that. And the other is now with the modified technology of this exablate, which is this focused ultrasound equipment, is to alter it so that now they're able to burn the hippocampus through this technology. So really a very exciting technology where you have outpatient brain surgery, where they come in walking, go home walking. Neuroprotection, so the idea is, yes, we want to stop seizures, but we also want to prevent brain cells from dying because of seizures or other disorders like stroke or dementia. So this is some work that me and my colleagues have done. There's this new compound called Peroxidoxins. This was actually found in the eye, and to see if lens proteins can be affected so cataract can be avoided, right? We wanted to see whether this Peroxidoxin 6, which has such strong antioxidant properties, is it present in the brain, right? So we wanted to answer, is Peroxidoxin 6 present in the brain first? Can we increase the amount of Peroxidoxin 6 in the neurons? And if we can, does increasing the amount of Peroxidoxin 6 prevent them from oxidative stress, right? So this was the questions we asked. We answered them. What we wanted to do was we want to take neuronal cells, divide them into 2 groups. In one group, we would increase the amount of PRDX, Peroxidoxin 6, and then have oxidative stress, expose them to oxidative stress on there, and then look at cell survival in both groups. So this is, you don't really need to do cell counting, but you can see many cells here are dead. You see so many more cells over here. This is where the peroxidoxin was increased in neuronal cells. So neuronal cell survival increased. In this, it did not. So this was kind of pretty prominent, right? It was an HD22, which is hippocampal cells. And then look at this. If you look at this, you can see almost no cells have survived here. And the ones with increased peroxidoxin, you can see many cells have survived here, right? This is in the HCN2 cells, which is the human cortical neurons. So clearly, this is very exciting. We corroborated this with cell counting, cell survival, and there was clearly significant benefit with increasing peroxidoxin than without it. So what we were able to conclude was that peroxidoxin is present in the brain. We can increase the amount of peroxidoxin in neurons. We developed a technology to do that. And then increasing the amounts of peroxidoxin in neurons protects them from oxidative stress. So the answer was yes for all 3 questions. And so there are other compounds that are being worked on now, because if we can prevent brain cells from dying, like in conditions like status epilepticus, right, it would really help in improving the lives of our patients from this perspective. Now, how did we increase the amount of peroxidoxin 6 in the neurons? We created what's called the TAT protein construct and did that. But we wanted to see if there was a drug or a natural substance that increases peroxidoxin, right? Being Indian Americans, we obviously looked at literature, and we were excited because we found curcumin as a potential compound. So we did another study in which we looked at oxidative stress, and we found that yes, curcumin does prevent oxidative stress, and was neuroprotective. But the question was, how was it neuroprotective? What does it do? And we found that curcumin actually protects by increasing peroxidoxin 6 in these. It might also increase some of the other compounds, but peroxidoxin 6 was a major compound whose expression it increases in neuronal cells and therefore prevents them from actually dying. In the end, I just wanted to tell you about this late-breaking technology, which is called augmented reality X-Vision, because surgery is an important part. So this is augmented reality. So the surgeon wears this helmet like this. And so as he's looking through these augmented reality glasses, in which have been fed all the MRIs and imaging of that particular patient, right? He sees through these glasses this. He doesn't see a skin on top. He sees beyond the skin because of all the imaging that has been fed in. He can see that he's putting in his equipment and this is where the equipment is. This is what the structure looks like. So it's a very exciting time, but I think we have to think out of the box. We have to be innovative. And these things that we just discussed, whether they are personalized care with CRISPR technologies, or it is artificial intelligence or epigenetics, or new technologies like TDCS, or Exablate with focused ultrasound, with incisionless brain surgery, or neuroprotective agents. All of these are the new technologies that will really revolutionize the way we treat epilepsy in the future. And we have to start thinking in terms of these newer technologies, because if we have to go beyond the 65 to 70% control, we have to really think differently. Because if we keep doing the same things again and again, using the same animal models to test all the new drugs, the only ones that will work are the ones that have already worked. And so the number of patients that they can help will continue to be limited. So hopefully I've been able to share with you some of the exciting new vistas in the field of epilepsy management. Again, I want to thank the Indian Academy of Neurology and the epilepsy subsection, Dr. Rawat, Dr. Surya, Dr. Gagandeep Singh for inviting me. And it was a pleasure to be with you all. Thank you.
Dr. Sangeeta, Sanjay Singh is here. So if there is any question, he can. He is in the transit, but he is in the lounge and he can answer the question.
Yes. Thank you very much, Sanjay, for joining us. I think we are running behind the time, but we can quickly take one or two questions. But it was amazing to hear all this. I mean, I feel I'm living in some different world because the way there's, I think the technology is moving ahead. Superb. Yeah, Sita.
So neurologists and neurosurgeons are going to be, it means, without them, even surgical procedures can be done.
Yes, that is something that they are worried about, because the Exablate technology can actually be done by both neurologists and neuroradiologists.
Yeah, but if the artificial intelligence take over, mostly maybe it will be done by the software personnel rather than the doctors.
Yes, that is a distinct possibility.
If there's a time, may I ask one question to?
Chhatrapati, please go ahead.
So, sir, thank you very much for the excellent talk. The thing is that my question is related to two topics, but the theme is same. One is the seizure prediction system and another is the neuroprotection. We have been talking about this for maybe last more than 50 years, but really nothing has clinically come out. Seizure prediction, people are working for last maybe 30, 40 years, and same for the neuroprotection, especially in the case of stroke. It has worked in the animal models, but nothing really has come into clinical. So how do you see the future, whether the near techniques will improve it, or we are at the same page as what we were at 20, 30 years ago?
Yeah, good question. I think, let me, in terms of seizure prediction, a lot of work has been done in the past, but, because of, I think primarily because of computing power wasn't really there, and the AI systems were not there. So this artificial intelligence and the increase in the computational abilities is going to really cause it. Like the model that we have worked on, it's not about looking at EEG waves. It actually looks at nodal frequencies across the brain And if they align in a certain manner, the AI system picks that up and it's predicting seizures, in that manner. So, the world is changing because of AI and our ability in computational models, which wasn't there even just a few years ago. So I think that was a limitation there. In terms of neuroprotection, you're right. We, just here in the United States, we have spent, some estimates say upwards of $30 billion in neuroprotection, that none of which worked. And you're rightly, as you said, the thing that is different between the animals and us is the brain, and we were testing it in animals. And so now the idea is to really, as in our study, is to test it on human cells, human hippocampal and cortical cells. And I think that's where things are. And then certain new methodologies and new compounds have been discovered, like peroxidoxins and others, which never existed in the past. And so I think it's an important part, because even in stroke or epilepsy, the whole thing is to not let the offending insult happen, so it causes brain cell death. But there's nothing to really cause neuroprotection. And so, we really don't want to give up on it. I think there's some exciting work being done by a few groups across the country. And I think you'll see some good results here shortly. And we are looking for natural compounds that can increase survival, like curcumin and others. And so one of the studies that probably can be looked at in India, which is going to be exciting, is we have a population that intakes curcumin regularly, and to see if the incidence of dementia is any different there than as compared to some of the Western countries. And that might provide some good data on that question.
Yeah, hopefully we can have some positive results. I think we should move on to Sanjay. Thank you very much. And unfortunately, we don't have much time, but your talk was amazing. Now we move on to Dr. Gagan Singh. Gagandeep, please, on epilepsy and migraine. May I ask you to share your screen?
Right.
Yeah.
Can you
right.
see my screen, and am I audible?
Yes. Yeah, you're audible and you can see very well.
Right. Thank you.
As well as you and the screen both.
Thank you. So thank you so much, the chairperson for today's meeting, Dr. Sangeeta. Hello. Hello.
Yes, sir, we can hear you. Please go ahead, sir.
Right. Okay. And at the outset, I just want to say a couple of things after these two amazing talks. One firmly entrenched in the present, and the other very futuristic. I draw your attention to this particular comorbidity of epilepsy, which is migraine. I'm also extremely grateful to my dear friend, Dr. Nirmal Surya, who has so much of enthusiasm, and as president of the Indian Academy of Neurology, he has been leading a string of initiatives, and this happens to be one of those. As also the chairperson and the convener of the epilepsy subsection, Dr. Sangeeta and Dr. Rathore. So, ladies and gentlemen, just as a prelude to the International Epilepsy Day, today we are having this CME for epilepsy professionals, and my talk is about exploring the borderland between epilepsy and migraine, and I'm going to be talking about masqueraders, mimics, and chameleons. It's basically one of the principal components of my talk would be to describe what the visual aura in people with migraine and the visual aura in people with epilepsy is like, and how we can differentiate between these two conditions. And then I would kind of intersperse it with some personal cases and about which we can have a discussion. So I would like to, the other thing I would like to begin with is two facts about the comorbidity of epilepsy and migraine. So there are enough community-based studies, particularly from Canada and so, which looking at epilepsy comorbidities, and these studies clearly suggest that migraine is twice as common in people with epilepsy in comparison to the general population. Likewise, people have not studied comorbidities of migraine, But there is no doubt about the fact, we all know from our clinical experience, that epilepsy is more common in people who have migraine in comparison to the general population. But I take you back to the 18th century, and this is Sir William Gowers, whom we all know that he was the first person to pen down a monograph on epilepsy, the first textbook of epilepsy, which he did in 1885. But several years later, he also wrote a monograph entitled The Borderland of Epilepsy, which comprised of 6 chapters. And as you can see, the chapter number 5 is about migraine. And Sir Gowers, in his introduction to this particular monograph, wrote, "For many years, I have kept a special list of cases which seem to be on the borderland of epilepsy, near it, but not of it." And specifically about migraine, he said, "Some surprise might be felt that migraine is given a place in the borderland of epilepsy, but this position is justified by many relationships." It goes on to say that they're often mistaken for each other, and sometimes their distinction is difficult. So, ladies and gentlemen, with this historical background, I take you to these cases. The first case is a 23-year-old gentleman who had auras for the last 18 years, and as many as 2 to 3 per day. And this is how he described and drew the auras. This drawing is from the patient, he always saw a black and white figure, so it's not colored, which seemed to move horizontally. And rarely he would have generalized tonic-clonic seizures. The question is this epilepsy or is this migraine? Or is it both, right? And then there is this other patient, 18 years old, female patient, who has about 1 to 2 events in a week. And she also likewise drew her aura, which involved the left upper quadrant, black and white, revolving lines and circles. And sometimes the faces of her family members could be seen within these circles. This would last for about 3 to 5 seconds, maximum 15 seconds, and has had only 2 generalized tonic-clonic seizures over the last 8 years. We'll discuss these cases a little later, and this third case is even more confusing, and this is the description provided by the patient. Would begin with a small star on a dark background in the left upper quadrant. The star twinkles and starts moving to the right, and as it does, its size begins to grow to that of a tennis ball. And the period of glowing also increases, and this happens for about 20 seconds. At times, I feel there is a fluorescent green computer text scrolling in the left upper quadrant. Sometimes I feel there is a LCD screen instead of the window on the left side of my bed. And I can see this regardless of the fact whether my eyes are closed or open. When these episodes recur several times in a day, these are followed by severe headache, which often lasts for 2 to 3 days and could be on either side of the head. And this is what this patient actually drew for me, made for me on his computer. This is the computer screen, and these are those visual phenomena which he describes as increasing in size, and these were provided to me by the patient. So question is, are these epileptic or are these migrainous? Going back to history, we know that William Gowers was one of the first to write an entire comprehensive textbook on neurological disorders, in which he discussed the visual aura of epilepsy as well as the visual aura of migraine. And he recognized that visual aura can sometimes occur as an isolated symptom of epilepsy, but also understood the fact that a greater difficulty is presented by the diagnosis of minor epilepsy, in which the only manifestation might be a visual aura. And Finally, he observed that when patient's account is all that we have to guide us, we must make a diagnosis from the general features. Sometimes they might be indistinguishable, not forgetting that one disease may unquestionably pass on to the other, and then some attacks might be of intermediate nature. So he clearly recognized that it could be sometimes extremely confusing to differentiate between the visual aura of migraine and the visual aura of epilepsy. Now, ladies and gentlemen, a picture speaks more than 1,000 words. And therefore, in my clinic, I always encourage my patients to draw their aura. We have a set of colored pencils and pens, and we provide them with a clean sheet of white paper, and we ask them to sit in a separate room and draw the aura. And these are all drawings made by patients, right, of what their auras look like. And we'll come to whether these are migrainous or epileptic in the next few slides. It's also important to have a migraine diary or an aura diary, as also a rating scale. And this patient has provided an excellent description in which he rates the severity of her visual aura. This is another description by a patient. So these spots start appearing, multiple colors in different, lasts for just 2 to 3 seconds. And this is very characteristically epileptic. Another patient with epilepsy who responded well to anti-epileptic drugs. This is how he described his aura. Something that moves horizontally. So a moving aura need not necessarily be migraine. It can be, particularly a horizontal movement can occur in epilepsy. Now, the other thing, this is again going back into the history. This is a description by Edward Living, who first wrote, he was the first person to write a monograph on migraine, which was published in 1873 in this monograph entitled On Migraine, Sick Headache and Some Allied Disorders. And this description speaks for itself. This is the entire description of a visual aura in migraine. It commences with a slight diminution of sight. Then the lower half, rather inclined to one side, appears as if hidden by some white object, luminous, held close to the eye between the object and the eye. Gradually, a half ring formed with serrated lines of prismatic colors appears in place of the darkness. And in 3/4 of an hour, the appearance ceases and a violent headache ensues. So this is a very classical description, a historic description, and this description applies even today when we talk about a migrainous visual aura. These are father and son, Wilfred and Hubert Airy, both of whom just had auras and no migraine. So they never had headache. So they just had typical auras without headaches. And they made beautiful descriptions and drawings, which are easily available on the internet, of the kind of aura. And I'll describe the multiple features in this beautiful, most explanatory diagram drawn by this father and son. The father was the royal astronomer of Britain, and the son was a physician, and beautiful descriptions they have given. But before that, let's come to a few definitions. So what, these definitions are important to our understanding of the phenomenology of a visual aura. So what is a phosphene? A phosphene is just the phenomenon of seeing light without light entering the eye. And you can experience a phosphene, you close your eyes and then just press against the eyes. And if you do that, you experience a sensation of light, and that is a phosphene. Photopsia are the occurrence of bright flashes of light in a visual field. Classical example, the old cameras, the flashes of the old cameras, when the flash would play, you would just get blinded. And that is what is a typical analogy to photopsia. Scintillation means bright flashing or sparkling light. And when the scintillations are accompanied by a scotoma or a dark or a white patch, it is known as a scintillating scotoma. Tdcs and fortification spectra are basically the same thing. These are zigzag luminous borders of medieval buildings, and you can see that here in this particular picture. And this is something which is very classical or characteristic of a migrainous aura. And then you have macropsia, where objects appear large, micropsia, where objects appear small, telopsia when they're far, pelopsia when they're near, and metamorphosia when there is a change in shape. So look at this. This is the fortification spectra, right? It's luminous, number one, at the edge of the scotoma, right? And it is multicolored. And this resembles fortification spectra, right? So this is, these are the characteristics of the border of the scotoma. And this entire thing is known as a scintillating scotoma. This is the town of Naarden in Netherlands. And if you descend by air, your aeroplane is touching down Amsterdam, you will come across this city which is surrounded by these waterways. And if it is bright and sunny, you can actually see the sun being reflected through the waterways. And this is again a very useful and appropriate analogy for the visual aura of migraine. Look at this multimedia, which we commissioned, and it was done for us by a colleague. The visual aura begins with a small, bright scotoma. Sometimes it might be dark, usually near the center of the vision. And then it gradually increases in size. Right? And the center then starts clearing up. Right? And the periphery is scintillating, multicolored with fortification spectrum. So this is the classical visual aura of migraine. The way it was represented was a bit too fast. In actual clinical situations, it happens much more slowly. So over about 5 to 15 minutes. But this particular representation was a little fast, just with the interest of saving time. So, ladies and gentlemen, I've summed here the differences between the visual aura of migraine and epilepsy. So, many of you, when you go to buy a house, or you have friends in real estate business, you know that what is the most important thing when you go to buy a house? It is 3 most important things are location, location, and location. And in differentiating the visual aura of migraine and epilepsy, the 3 most important things are duration, duration, and duration, right? So the aura, visual aura in migraine is, in epilepsy is very short lasting, usually few seconds, but always less than 5 minutes. And the migraine aura is more than 5 minutes, usually 15 to 20 minutes, but may also go up to 60 minutes. And there is the concept of a prolonged aura or a persistent aura without infarction when the aura goes on for a week or so. There are other differences as listed in this table. I'm not going to read each one of them, but none of these differences are absolute. I showed you two cases in the beginning. Both were black and white auras. Black and white auras, it is said, typically occurs in migraine. But I'll show you what was the outcome of those patients. But then going back again into history, the word aura was initially used in the 18th and the early 19th century in context of epilepsy. In fact, this monograph on migraine, which I referred to earlier, in 1873 by Edward Living, doesn't use the term visual aura. He never used the term visual aura. In fact, he used descriptions such as blind migraine or ophthalmic migraine to describe the visual phenomena associated or preceding migraine, right? The word aura was adapted into the headache terminology somewhere in the 1990s, and this was perhaps the first paper by someone known as J.N. Blau, whose migraine prodromes separated from the aura of migraine. And the second international headache classification, which I think was published in 2004, not the first, used the terms migraine with aura and migraine without aura. In the first classification, the first ICHT classification, the terms classic and common migraine were used. So aura is a recent adaptation to the migraine word. Just look at, we know now that this aura, the basis of the migraine aura is the depolarization wave, which proceeds at 3 millimeters per second. So it starts off usually in the occipital lobe, producing a visual aura. Then it kind of migrates further. So if the aura continues, some people with visual aura might have a somatosensory aura. It then migrates even further anteriorly, and these patients would have a hemiplegic migraine. And then once it spreads even more anteriorly, there might be an aphasic aura. All of this happens, the cortical spreading depression at a rate of 3 millimeters per second, and this has been well validated, number one in experimental studies, as well as functional MRI studies in patients who are having a visual aura. In contrast, in epilepsy, and this is taken by, these are descriptions by individual patients in this particular paper in Brain on occipital lobe epilepsy. And this is how patients describe their auras. And these were all patients with confirmed occipital lobe epilepsy. And I have put down these descriptions verbatim, but I have described them I have put them down in different colors to emphasize that the visual aura in epilepsy the auras are most often colored as compared to black and white auras in migraine. So then coming to this patient, which we discussed, what do you think about it? And this is what the MRI showed. There was a structural lesion involving the left occipital cortex, as you can see in this MRI. And this patient responded very well to anti-seizure medications. Likewise, this other patient who had these circling lines, there in the left upper quadrant, there was a lesion in the right occipital lobe, as you can see here. And this patient, again, likewise responded well to anti-epileptic drugs. What about this patient who was really complicated and made all these elaborate diagrams for me? This is what the MRI showed. There was a small calcific lesion involving the lingual gyrus or the parahippocampal gyrus, and you can see the calcified lesion. And this patient is also doing reasonably well with anti-epileptic drugs. So there is this condition known as typical aura without headache. And I know that a number of our neurology colleagues and some very senior neurology colleagues have a typical aura without headache. So they don't have headaches and they just have the aura. And this is a drawing provided to me by one of the patients. And you can see that she has very elaborately described the evolution of the aura. You know, how it starts from a small central spot and then gradually, and she has written the time also. It begins at 1:32 and then 1:33 and minute by minute. These drawings are minute by minute by her, right? And incidentally, this patient initially had very classical migraines with aura, but later on what happened is the headaches disappeared and she would just have the typical aura. And this is believed to occur with an incidence of about 4% of all patients with migraine with aura. You can then have ictal and post-ictal headaches. And I'll go on to describe some epilepsy syndromes with ictal and post-ictal headaches. These are the ICHD-3 criteria for ictal and post-ictal headaches. The term hemicrania epileptica was used in the second headache classification, but was discarded by the third headache classification. And then you have this condition known as migralepsy. And in ICHD-3, the term migralepsy has been, has not been used. Instead, they use the term migraine aura triggered seizures. The two characteristics that are extremely important are, one is that the epileptic seizure should occur within 1 hour of the migraine headache. And the migraine should be migraine with aura, and it cannot be a migraine without aura. So these are the two most important criteria for migralepsy as it was earlier known, but now the current accepted terminology is migraine aura triggered seizure. It was first described by Leno in his textbook on epilepsy. And if you read this description, it is very difficult to say whether this patient has migraine or this patient had occipital lobe seizures, or was it a case of migralepsy? And I'm not sure, because at that time there were no MRIs. So what actually was wrong with these patients, it is difficult to say. We have these two types of childhood occipital epilepsy. One is the Panayotopoulos syndrome and the Gestow syndrome. Here listed are the differences between the two conditions. Migrainous headaches are a very prominent feature of late onset occipital lobe epilepsy. You can see Panayotopoulos occurs in younger children, and Gestow type of malignant or not so benign occipital lobe epilepsy occurs in older children. There are these characteristic differences between the two conditions, but one of the important differences is that many patients, a good number of patients with the late onset occipital lobe epilepsy of Gestow have headaches which follow the seizures, the visual seizures. This late onset childhood occipital epilepsy is quite rare, but then headache is a very prominent feature of this particular condition. And we know that the fixation of sensitivity is one of the important features of the Gestow syndrome. We should always suspect it when you have children who when you start seeing occipital spikes or paroxysms of occipital spikes when the child closes his eyes. And you can actually then hand over a pair of dark goggles with which again the occipital spikes would appear. It's basically eliminating fixation. Fixation eliminates the discharges. The other thing that you really need to differentiate is from scotosensitive epilepsy, which you can do so by handing over the patient and making the patient wear a set of semi-transparent goggles. Lastly was this doctor who presented with 26 years, who presented with the first seizure, and she was tying her shoelaces, and then she moved her leg, but she continued to see images of her shoe for quite some time. That's polynopsia, and this was followed by intense headache. And the MRI showed this kind of granuloma in the occipital lobe. She also had multiple granulomas and in the liver and various organs, and therefore we made a diagnosis of tuberculosis and started her on anti-tubercular treatment in addition to epilepsy medicines, and she's doing quite well with that. So this is the phenomenon of polynopsia. And just to apprise you of a little bit of anatomy of the occipital lobe, and where does polynopsia arise, and where do other phenomena like prosopagnosia and various other types of spontaneous positive and negative phenomena associated with the occipital lobe arise. So this is the calcarine sulcus. Superior to this is the cuneus, and a lesion here would lead on to inferior quadrantinopia. Below the calcarine sulcus is the lingual sulcus, and this is important because this is important for face recognition. The phenomenon of visual snow might occur here, and the lingual gyrus, this purple thing in front of, continues anteriorly as the parahippocampal gyrus, and is separated by the collateral sulcus from the fusiform gyrus. And if people have lesions, whether epileptogenic or otherwise, of the fusiform gyrus, they can have problems with face recognition, visual snow, and palinopsia can occur. So this is a little bit of anatomy of the occipital lobe. And then coming to this curious, again, historical phenomena, this is a photograph of Charles Lewis Carroll, whose real name was Charles Ludwig Dodgson. We all know that he wrote Alice in Wonderland, in which Alice falls down into a rabbit hole and then, eats some cake and drinks some lotion, in which she becomes very big and then becomes very small. Point of historical interest is, was Alice in Wonderland, did Lewis Carroll have migraines with aura? And was Alice in Wonderland inspired by his auras? And that is a different story. I will not delve into it, but just to apprise you of what is Alice in Wonderland syndrome. And this is the initial description given in a paper in the 1952, where this particular neurologist described 7 cases. He began with that they are all above average in business, or they're all good housewives or mothers. And then he goes on to describe the episodes. Some of them were epileptic, some of them were migrainous. This is how the patients described it. And this is another description by John Todd, who was a British psychiatrist, who actually labeled all these phenomena as Alice in Wonderland syndrome. If you read Alice in Wonderland, you find suddenly she becomes big in size, then becomes small in size. There are animals who have metamorphosia. So all of this happens in clinical context too, most often in context of epilepsy or in context of migraine. The other thing is viral encephalitis, infectious mononucleosis, and all these conditions. Most often it occurs in adolescents, and these descriptions are very typical of Alice in Wonderland syndrome. Last but not the least, you can have, this is a description from the 18th century of a patient who presented with visual aura and had very typical migrainous headaches, in whom the autopsy, this is Gower's case, in whom the autopsy clearly showed a tumor involving the parieto-occipital lobe. And indeed, there have been in literature, and we have seen cases where you have a very typical migrainous-like visual aura, but it is due to a focal cerebral lesion. And this particular paper by Gordon Plant and his colleague, if you have visual auras which begin for the first time in the 4th or the 5th decade, the auras are short-lasting, they're always side-locked, or are associated with a visual field defect, you should always undertake structural imaging to rule out the presence of a structural lesion. A word about the genetics of epilepsy and migraine. We know that there are a number of disorders, monogenic disorders, both for migraine and epilepsy. And then we also know that genome-wide association studies have been done, and a number of loci have been found, which predispose patients both to either epilepsy or migraine. But there are also conditions, genetic conditions, which predispose people both to migraine and epilepsy. And we have listed these in this particular review that we have recently written. And indeed, we feel that there could be a shared susceptibility, and there are some studies which have looked at a shared genetic susceptibility. That means people with epilepsy have an increased chances of a family history of migraine and vice versa. So there is some evidence in literature for this. So ladies and gentlemen, if you allow me to conclude that there are characteristic distinctive features between the visual aura of migraine and epilepsy. I am not sure, and I personally feel that we should not name them, they should be named differently. The visual aura of migraine should be named differently from the visual aura of epilepsy, to make things clear. But clearly there are immense number of confusions. There are chameleons, there are mimics, there are masqueraders, and it is important to be aware of these if we have to treat our patients well. Thank you so much.
Thank you, Gagan. I think it was an excellent talk. I mean, I really enjoyed that video of scintillating scotoma, which your colleague had made, I think. Sita, yes, go ahead.
Yeah. Thank you, Gagan. Yeah. So it's a great work. I think it's the research is going to be published soon.
Yes.
Yeah, we are struggling to get it published.
Yeah.
Right. Yeah.
But this drawing from all patients in a different room with the color pencils is really worth, I also would like to put it to action, because if you tell them in front of you, I think they often don't do. So,
yeah, we tell them to go to a different room, or sometimes they would just go back home and then
bring next time.
They will just WhatsApp it across.
Right.
So, yeah, we have two questions in which I think they have given a full history of the patients.
So
the first question is the 13-year-old adolescent with non-consanguineous parentage with recurrent stereotypic episodes of 6 per day consisting of pain, abdomen, headache, vomiting, visual and sensory aura. Non-responsive to means propranolol, amitriptyline, and evaluation was normal including CT abdomen, and she responded to anti-seizure medication, that is levetiracetam. So will you consider occipital lobe epilepsy in this? That's the question.
Yeah. Now, this, in fact, since there are so many experts here, Rathore and Dr. Sita and Sangeeta. So two things. I was sometime back talking to or listening to a talk by, in fact, Dr. Ravi Shankar, and which he clearly said that whenever I see a patient with migraine with aura, my first choice is always an anticonvulsant and not propranolol or any other prophylactic drug. Right. And the other thing is we need to understand is that there are a number of trials. I might personally not agree to it, but there are a number of trials available in literature on the role of levetiracetam in the prophylaxis of migraine. So and in these trials, levetiracetam has been found to be as a useful drug in the prophylaxis of migraine. So just because the patient responded well to levetiracetam, it could also mean that the patient had migraine and he improved because of that. I personally don't think so that levetiracetam is a very good drug for migraine. In fact, I feel that patients with who are on levetiracetam, sometimes they have an increased frequency of migraine. But yes, it can be really confusing, and these are some of the issues. I think whenever you are in doubt, it might be useful to start anti-epileptic drugs because they will cover for both things.
Yeah.
Yeah.
Okay. Thank you. Rather, any questions?
Sir, very excellent talk and excellent illustration. Coming back to the migralepsy, do you think it is still exists, or it has been proven that all these patients with so-called migralepsy have actually occipital lobe epilepsy and visual aura, which is confused with migralepsy? So particularly that term, do you really we need to continue using that? Or personally, I have never seen a patient of like this migralepsy or with migraine subsequently leading to the epilepsy aura or something like that. It always, I think it's occipital lobe epilepsy, which has a visual aura. So what is your take on that, this migralepsy concept?
You're
Gagan, I'll
absolutely
just continue Rato's question. We see few patients who have migraine, and during the episode of migraine, they have episode of loss of consciousness without anything to suggest either hypomotor seizures or bilateral tonic-clonic seizures. So please comment.
So, Dr. Rathore, you're absolutely right, and I completely agree with you. It doesn't matter whether I agree or not, but the world agrees with you, because the term migralepsy has been discarded. Because if you clearly, closely look up these cases and look up all the case reports of migralepsy, there is no convincing evidence that there is some entity like migralepsy, and which is why the International Classification of Headache Disorders, the 3rd edition, has discarded the use of the term migralepsy. The second thing is, suppose a patient with migraine presents with confusion or loss of consciousness. So one thing is whether it is not migraine and it is a seizure, which could be responsible for the loss of consciousness or the confusion. The other thing is there is one type of migraine in which loss of consciousness can occur, which is the basilar artery migraine. It is no longer again called basilar artery migraine, but it has basilar symptoms. So that can clearly be associated with loss of consciousness. There is another condition known as acute confusional migraine. And acute confusional migraine, again, the term is not accepted by the ICHDS, but there are a number of case reports of acute confusional migraine. They occur mostly in children and adolescents, and there is a lot of confusion and followed or accompanied by the headache, and it usually resolves following sleep. And the confusion has been clearly documented. So there are these, entities. Some of these are gray areas. Some of these are not well documented. But these could be reasons why people with migraine lose consciousness or become confused.
So if I can add to that, in clinical sense and in a real scenario, a patient with headache and unconsciousness, majority I've seen either they have a non-epileptic events like a pseudo seizures, or they may be related sometimes severe headache precipitating a syncopal event. So those are unrelated to migraine, obviously, but patient presenting with a severe headache, a migraine patient presenting with a loss of consciousness, usually in the clinical or in a clinic, the common diagnosis is either a pseudo seizure or a non-epileptic event or a syncopal event. Yeah. Obviously, although basilar migraine and impaired confusional episodes of migraine, but those I think is very, very rare.
Yeah.
Yeah, thank you. Yeah, Sangeeta.
Chaturbuj, can you, I think he will do the vote of thanks to all.
Thank you, madam. On behalf of Indian Academy of Neurology and its epilepsy subsection, it is really a privilege and a pleasure for me to say a vote of thanks to all the people who has been involved in successful organization of this program. At the outset, I would thank Dr. Nirmal Surya, President of Indian Academy of Neurology, and Dr. Sangeeta Rawat, the Chairman of the Epilepsy Subsection, for envisaging this program and doing all the work for this successful organization, including contacting all the speakers and setting the times and everything. So thank you, sir, and thank you, madam. I also thank our international speakers, Dr. Sanjay Singh, who had been a past president of IANA, and Dr. Prakash Kotegal, who is the present president of IANA, who took time from their busy schedule and especially at very odd hours in the morning, 6:30 or 6 o'clock, to be with us. And so I really thank both of them from all the epilepsy fraternity from India. They have been always keen in helping all the programs of Indian Academy of Neurology and has been always keen in sharing their experience with the Indian epileptologists and Indian neurology fraternity at large. Thank you, sir. I also thank Professor Gagandeep Singh, the President-elect of Indian Academy of Neurology, for excellent talk on a very controversial topic and very well elucidating thing. And he was also, he along with Dr. Sita Jalaxmi, both were also the integral part of this program. So thank you, both of them. And at the end, I thank the digital team for all these logistics, which has been flawlessly arranged. So with that, I think we have come to this first program of on the eve of International Epilepsy Day. And I request all of you to at least do whatever you can do from your side to spread the awareness of the epilepsy and spread the love for people with epilepsy. With that, I think we can conclude the session. Thank you very much.
Chaturbhuj, let everyone join tomorrow also for the evening session organized by Indian Academy of Neurology.
Yes, sir. So tomorrow there is a public platform session, public awareness session from the Indian Academy of Neurology, starting at, I think, sir, 7 o'clock, sir?
5 p.m. No, sir, 6 p.m. 6 p.m.
6 p.m.
Okay, sir.
And
so
they can share the link of YouTube to their support group.
Yes, yes.
Thank you, sir. Thank you. And I think have a nice evening, everyone.
Yeah, and thank you for the delay, I think. Sorry for the delay. Sorry.
Yeah. Thank you. Thank you.
Thank you very much. Yeah. Bye.